Disability Alliance. Thank you. Welcome to this special session of Awareness in Action with the South African Federation of Mental Health as we commemorate Psychosocial Disability Awareness Month 2026. We are going to record this session for later viewing. Thank you so much for joining us. I'm going to hand over to Michelle to introduce herself and to share more about their campaign this year. Thank you.
Thanks so much, Melanie. Thank you. Good afternoon, everyone. As Melanie said, it is Psychosocial Disability Awareness Month, which we commemorate every year in July. And for 2026, the SA Federation for Mental Health focused on the theme from institution to inclusion, the importance of community-based mental health care. And the aim was really to emphasize the need to prioritize and increase investment in community-based mental health care, but also to highlight how community-based mental health care fosters meaningful inclusion and integration for persons with psychosocial disability. So before we hear from our wonderful speakers, who I'll introduce you to in a moment, I wanted to provide just a bit of context about what community-based mental health care is. So community-based mental health organization are NGOs that really provide services outside of our traditional institutional settings, and as near as possible to places where people live, where they work, and where they study. Community-based mental health care and their services are really informed by a person-centered recovery model, which has an approach that, empowers individuals to direct their own care, with a real emphasis on psychosocial rehabilitation, as well as on the promotion of overall well-being. And when we look at community-based mental health care, we really see four main hallmarks about it. And they are one, that, community-based mental health care really provides accessible care, providing mental health services at community levels where people can access the care that they need, including outpatient care and therapy. Community-based mental health care also aims to provide more human rights-based informed care, especially when you compare it to these traditional institutional settings and institutional care, where people can often face, social isolation, inadequate living conditions, resource shortages, and overcrowding. When it comes to community-based mental health care, we also see that, they're able to link people to other necessary social services and structures, which really promotes that overall holistic recovery. And then the last hallmark is that it's cost effective, right? Community-based mental health care can provide care at a lower cost. And it really is an efficient way of making use of limited resources, especially in a country like South Africa. And then when we were looking at, community-based mental health care and the fact that it really fosters inclusion for persons with psychosocial disability, we really saw three ways that it does this. And the first is tailored interventions. And you'll hear a bit more about tailored interventions from our speakers today. But the fact that, tailored interventions which are designed basically for persons with disability, for psychosocial disability, to create links and have positive relationships within their communities. Community-based mental health care also fosters, family reunification, really facilitating that interaction again and integration with families for persons with psychosocial disability, but also promoting participation and the involvement of persons with psychosocial disability to really be involved in their own decision making as well, especially when it's related to their own health as well as life choices. We really love this quote that was shared by one of our community-based member organizations, Indlela Mental Health. And they said that community-based mental health care is far more than an alternative to institutionalization. It is a model of dignity, inclusion, and empowerment. But before I continue and go over time, I wanted to then introduce our first speaker, Carol Bosch. Carol is the Deputy Executive Officer at Cape Mental Health. And really, Carol, I would really love it if you could please unpack a bit more about the importance of community-based mental health care, and maybe also share more about how Cape Mental Health's programs really encourage inclusion. I'll stop sharing my screen so you can start sharing. Thanks, Carol. Over to you.
Good afternoon, everybody, and thank you again for inviting us to share about our program. Okay. Okay. So thank you very much again. My name is Carol Bosch. I'm the Deputy Executive Officer at Cape Mental Health. And I'm really pleased to be able to talk to you about community-based care, as this is really something that we really do believe in. That is just an outline in terms of my presentation. I must admit, when I was told I only had 15 minutes, I thought, what you include, what you exclude, it becomes very difficult to decide. So this is going to be a rough ride in terms of the program that we have. But if you need any more information or any additional, if you need anything additional, you can let me know, and I'll be more than happy to assist you. So in terms of for us, so this is really the program that we believe in. So we feel that people with a formal diagnosis of a psychosocial disability or mental illness or psychiatric disability, what it used to be known as, sometimes needs assistance in different aspects of their life. And this would be living, social work, as well as learning environments also. And we really feel that in terms of having the psychosocial rehabilitation, it's the one way to be able to manage their symptoms as well as to let them function at a better level. So in terms of our psychosocial rehabilitation program, it is designed to improve the lives of people with the psychosocial disability in terms of the emotional, cognitive, and social skills that is needed to live and work in their respective communities and to live as independent as possible. So we all know that before the 1970s, there was a lot of focus in terms of people with disabilities being isolated, being institutionalized. That was the norm. And after that, we saw that the institutionalization became more acceptable. And so people were, they were then, allowed to go back into their respective communities. And so now there's a greater focus in terms of helping people with mental health conditions to live as independently as possible, but also to become fully integrated within the communities. So no longer do we see that they are kept aside somewhere. They need to be really integrated within the communities, which means that the community needs to be able to cater to their needs. So the value of psychosocial rehabilitation is that it is person-centered. The focus is on the service user first, and that remains the most important thing. That whenever you're looking at any psychosocial program, it's got to be focused on the needs of the service users. The focus is on increasing functioning or performance. So, we know that very often in terms of psychosocial disabilities, there's a lot of focus on what people can't do. And we say, look, that for us is not important. We want to see what the person is able to do and increase what they're able to do. For us, it's very important that the person is involved, that they have a choice. So they have a choice whether they want to take part in our program. They have a choice in terms of which aspect they want to be part of. It's not about forcing the person. The person comes in, and from the beginning we say, this is your choice. Whether this is going to work or not, it is your choice. We need to support you, but you do have a voice in all of this. So all of our programs do go hand in hand with a lot of self-advocacy work or advocacy work also taking place. As indicated also, not all people with schizophrenia are the same. And so we really take into account the individual's needs and what they want in terms of their program. They might live in the same community, they might have absolutely everything the same, but their needs would still be different. And we feel that it's important that you do take that into account. Also, in terms of that, we're also very much aware that the person lives in a community, and all communities are different. And you need to take that into account also. So you need to take into account where the person lives, where they work, the learning that is taking place, and also what kind of socialization is also taking place in that community. It's important for us that we provide the individual support as long as the person needs it or wants it. So it doesn't stop simply because you're changing from one program to another. We will continue to provide the support as long as the person needs it. It's for us very important that we focus in terms of the potential of the person. When people come into our program, they are not at their best. You know, they've been through difficult times. There's often issues in terms of families. The person is starting the recovery journey again in terms of medication, in terms of interacting with family members, interacting with communities, interacting with resources. And so it's important to focus on what is the potential within that person, and not in terms of the past, what has happened, because I think a lot of time is spent in terms of the past, and not looking at what is the potential of this particular person. So within our PSR services, we've got different kinds of services. And again, these are the services that you can access if you want to. So it's crisis intervention, it's basic support, it's treatment, it's rehabilitation within the program. It's about self-help. It's about enrichment. There's a lot of work that's being done in terms of the protection of rights. And then with all of this, we also do the case management. So with all of the types of services, there would be different outcomes. And, you know, it changes from when the person comes into the program, while the person is in the program, and then also when the person leaves the program. But it depends on that person, what are the kind of services that he would require.
So sorry, quick one, Carol. So sorry, your slides aren't moving, so we're not too sure if you're speaking to slides. Sorry.
So where are you? Can you see I'm at continuum of care?
Oh, okay. No, we're still on the first slide.
Oh my word.
Sorry. Sorry about that.
See?
It's been okay though, but yeah, maybe if you just move down.
Is it moving now?
No, we can't see that it's moving from our side.
And now?
No.
Still
It's just being in the main. Yeah. I'm not sure if you press present that it might on PowerPoint.
It is.
Maybe if you
nothing on my side.
Yeah. If you stop sharing and maybe share again. Yeah. No problem. Thanks, Carol.
Okay.
Yeah, now we can see on continuum of care.
Oh, you see. Okay, let's see if I do. Are you still on continuum of care?
Yes.
Okay, let's hope it continues.
Thank you. Thanks, Carol. No worries.
Sorry about that. So in terms of continuum of care, so when the person comes into our program, they're able to access our social work services. And the person is allocated a social worker, and the social worker then works in terms of assessments that is needed, and whatever interventions are going to take place. The person would have an option of joining a group. So previously we used to have Rainbow Foundation, and that is we would do a lot of referrals to, and the person can then, while they just come from hospital, they're sort of starting the recovering journey, they could then go to Rainbow Foundation. We no longer have these groups in the different communities. And so now what social workers do, they either create their own groups or they would refer if there is an appropriate group within the community. When the person is better, we then refer them to Fountain House. And this is where we're going to be spending more of the rest of the presentation in terms of what Fountain House offers. So I'll explain a little bit later in terms of Fountain House, and then in terms of the peer support also. So this is the continuum of care that the people would have access to while they're within our program. So now I hope it's going to move. I'm not sure if it's moved, but anyway. So I'm going to talk about Fountain House. So we've got two Fountain Houses. The one is in Observatory and the one is in Mitchell's Plain. And the Fountain House, what they do is they implement a work order day program where members receive on-the-job training in a variety of skills through their participation in the activities of the program. So a lot of people were coming either from hospital or they've now just started, they want to sort of explore skills development. They need to get familiarized, they need to familiarize themselves again with the activities that needs to take place. So for some it would be totally new. For other people it would be where they sort of re-entering again. So it doesn't matter where you are, we're more than able to assist you. So what happens is that we develop a comprehensive care plan with all the members. So you need to indicate what is going to be your care plan while you attending the program. There's a lot of focus on monthly adherence to medication, as well as peer support activities. And all of this is done to limit relapses and reduce hospitalizations. We do a lot of psychoeducation and training to facilitate reintegration into society as well as the workplace also. And the activities that increase the levels of functioning in the 4 life areas. So these different activities in the afternoon that focuses on whether it is in terms of medication adherence, but it could also be in terms of conflict management. It could be in terms of how to open up a banking account. All of those kinds of things could also take place within the program. And then very importantly, when needed or if indicated, we also work with the family members because we know that the person is not alone. There's a family that often also needs to be supported. So in terms of the Fountain House program, so like I've said, it's a vocational program, and there are 3 units within the program: catering, admin, and employment units. So when the person come in, they can decide. So they spend time in the different units initially, and then they decide which unit they want to attend. And then they meet with the rehabilitation worker who will then say, okay, fine, works out the plan of action for them in terms of what the objectives would be in terms of meeting what they want to meet within the program. And this is often, they monitor it and they then check, they have meetings to just assess where the people are. So while attending the program, the member continues to receive services from the social worker as well as the rehabilitation worker. And often there are discussions between the two to check what is happening, how is the person, and if there's any issues, the social worker will be alerted because she will or he will be able to assist in terms of providing additional support to them. When the member is ready, they encourage them to do applications for learnerships or internships or job applications. And this is supported by the job coach, which is also part of the program also. So they have access to these services until they feel they do not need the services anymore. So, we won't terminate any services as long as the person feels that they need the service, they would be able to access those services. So we have some members of Fountain House that are within the open labor market, they're employed, and every now and again you would get a call from them because maybe they're not doing well or maybe there's some problems that they're experiencing. or maybe there's an issue in terms of the job place and they want the job coach to come and assist. So as long as they need the service, we will continue to provide that service. So these are just some of the activities in the different units. I tried to get different photos of the members, and then they sent me where they've blocked out their faces because not all the members agree that we can use their photos. So the ones with the mask were actually still better. But there's different activities, and again, it's voluntary. You can decide what you want to do. You decide how often you want to come into the program, which unit you want to go to, and then, you know, what the focus of your rehabilitation is going to be. It's a very vibrant program, so people come in on a daily basis. It's a structured program, so you sit in the morning, you go through what's going to be happening during the day, and you can decide what activities you want to do. We also, within the Fountain House program, we've got a very good catering unit, and they sell meals to staff members even. And so in terms of that, the members are able to come. They really become part of the Cape Mental Health family, because you get to know them in terms of when they bring the meals, their interactions when they come and fetch the post and things like that. So in terms of, that is the Fountain House program, but within the Fountain House program, we also have the peer support program. So this started in 2019, where we did the training of 10 peer supporters. And the peer support program has really, so this allows somebody with a lived experience to support a Fountain House member. So again, it's absolutely voluntary. If you want to speak to a peer supporter, you can schedule an appointment, and they have a discussion. And often, it's about, often as professionals, we might not know the real experiences. And so it's important for somebody to be able to speak to somebody who knows what they're talking about when they say they're hallucinating or there are issues or whatever. And this has really complemented the work of our professional counseling services. And we've seen how people are able to really benefit from this kind of interaction. Within Cape Mental Health, we've got 2 peer supporters that are employed also. So we've got one at Fountain House Observatory and one at Fountain House Mitchell's Plain also. So just in terms of the benefits of why we like this program, it's really a preferred method of treatment. It's cost effective, and we've seen it successful. We utilize community resources or the alternatives that exist within the community, so the person is able to access things within their communities. It really does reduce hospitalizations. We don't see as many hospitalizations happening. It really empowers people by, especially in terms of their self-confidence. You see when people come into the program, what they're not able to do. And it's amazing to see the growth and development as time goes on. It really increases the functioning of the person, because it's focused in terms of, what the person is able to do and how we can expand that. And it fosters recovery and social support also. So you see people becoming much more confident in the abilities to even communicate with all of us. So I really hope this video is going to play now.
Yeah, I think you just need to go to the slide again and play it, Carol. Yeah.
Okay, let me see. I'm so sorry about this, but let's see.
Yeah, it's on the screen now.
My name is Andrew Abrams. I'm a person with a lived experience of a mental health condition. I was diagnosed with schizophrenia, and the first time I was hospitalized or admitted in a psychiatric hospital, I felt totally isolated, confused, broken, didn't know what's gonna happen in the future. And yeah, when I got out of hospital, the people didn't understand me at home and in my community. They were discriminators against me, calling me names like crazy and etc. Yeah, making fun of me of being hospitalized. And yeah, I was totally lost and didn't know what the future holds for me. I didn't know that there was help for me out there. In, in a, I didn't know that a place like Fountain House exists. I was so broken before I joined the Fountain House. I was stuttering a lot and were broken, but Fountain House really helped me build up my self-esteem, my confidence, and I feel totally normal. I felt hope. Hope came my way, and yeah, it felt good being included in a psychosocial rehabilitation program, in a safe space where I can be myself and not fear to be judged. I can just be myself. So I was in the psychosocial rehabilitation program called Fountain House. I joined the admin unit. So we learned like photocopies, filing, managing the phone, working with referrals, and also doing the post from Fountain House to the head office called State Mental Health. Yeah, it felt good being included. I say when I first was admitted, I had a lot of thoughts and like, is my life ever gonna be normal again? And yeah, my life is normal with Fountain House, with the support of Fountain House, and also my social worker give me great support. And yeah, Fountain House has also provided me with work opportunities. I worked at Pick and Pay, I worked at Posini, I worked for Coast and Country. Coast and Country were working with Coke products, and currently I'm doing an internship as a mental health advocacy officer at Fountain House, and this is the fourth work opportunity Fountain House has given me, and yeah, I feel totally safe at Fountain House, and my life is totally normal.
So you might ask why we do this and why we believe in this program, and this is the reason. I think it's because of many of the Andrews that come through our doors, and you're able to see how we're able to transform their lives, how they're able to eventually become advocates for people who have similar diagnoses as them, and how they're able to bring hope to many people. So this is the reason. I think I mean, I've worked at Cape Mental Health for 30 years, and I still am shocked and pleasantly surprised when I see how we're able to transform the lives of so many people. So for us, PSR is really a journey of recovery. It's not a destination, because we all know also that in terms of everybody's journey, there are ups and downs. And it doesn't matter, as long as we're able to provide the support that they need. I think it's very important. And as long as they're able to access those services, I think we continue to do quite well. So thank you very much. I'll stop sharing now.
Thanks so much, Carol. Thank you for, just sharing your insights and your experience. And I think, hearing from the person with lived experience, this drove home the important work Cape Mental Health does do and has been doing. I mean, Cape Mental Health is the oldest mental health organization in the country, over 100 years old. And they continue to do incredible work in the communities that they service in the Western Cape. So thank you for sharing those insights, Carol, and just, reminding us about the importance of community-based mental health care. Thank you. So next, thanks, Carol. Next, I would like to welcome Rebecca Nabirabwe. Rebecca is a community mental health specialist as well as the regional program lead at StrongMinds Uganda. Rebecca will be joined by Christine Atuginza. Christine has lived experience, and they will share some lessons with us from StrongMinds Uganda with regards to community-based mental health. Thank you so much, Rebecca. I'll share my screen for your presentation. There we go. Over to you, Rebecca. Thanks.
Thank you, everyone. My name is Rebecca. We believe at StrongMind that the circle is the treatment. So we bring free, evidence-based, culturally acceptable and relevant therapy to the underserved and under-resourced communities. So StrongMinds, we work with the government structures with across Africa to integrate and embed free group therapy into the existing multi-sectoral public infrastructures, and these include the schools, the community, the health system, and also correction centers. We are in prisons. So we make sure that we integrate mental health care in those structures. And our program is delivered by lay trained facilitators. These are community health workers who are recruited, trained, and empowered to offer a low-cost proven model that we call interpersonal psychotherapy for groups within the communities that they live. We do not fairly community facilitators elsewhere, but we work within the structures of the community. So those community health workers do offer this proven model of treatment to clients within their community, and it's proven that it's one of the most cost-effective way to improve mental health in Africa. So as of now, StrongMinds, through our model, we've reached 2 million people treated of depression across the 34 districts in Uganda, and at a cost of $13 per patient that we reach out to or per patient that we treat. And since 2024, we've achieved a 78% scale. We've scaled at 78% to the different countries and to the different districts that we live. Like I said, our intervention, we believe that the circle is the treatment. So we use the lay community workers, as they've seen in the photo here. Those deliver the interpersonal psychotherapy in groups for 6 weeks. We have homogeneous groups, women that sit in therapy, you can take back, that sit in therapy for 6 weeks. They share their challenges. They share the symptoms of depression and the experiences that they have gone through as they experience depression and anxiety. Then by the end of the 6 weeks, they are able to live productive and satisfying lives. So below is our client journey. Michelle, we can move. So this is our client journey. Within the communities where we identify the community health workers, they start with mobilizing the communities. and sensitizing them about mental health, its effects, the signs and symptoms, but also majorly take them through depression and anxiety. So after they have sensitized and the communities, then they are able to subject clients who identify with the symptoms of depression to a screening tool we call the PHQ-9. That is the Patient Health Questionnaire 4. That is the one that we use as our initial screening tool to assess those that could be having symptoms of anxiety and depression. So from that, then those that score a 5 and above on that tool are then subjected to the second screening. And this second screening is a pre-group phase where we now ascertain the symptoms of depression that were seen at the initial screening, but also help the client to identify the triggers of their depression and be able to set goals that they will be working on as they join the therapy groups. And also helping the client to consent for therapy. So after that second screening, then they consent for therapy and then start the therapy phase. In the therapy phase, that's where now they start sharing about their challenges, what could have triggered the way they felt, and what strategies they can put forward in order to overcome the challenges that they're experiencing and the depression symptoms that they are going through. Then after 6-week therapy, we terminate the groups, and the women, what we've seen is that even after termination, these women have built a cohesive social support system and they continue living together. But after that, we do not stop there. We do a post-evaluation after 2 weeks to assess the symptoms of depression that the clients had at the beginning, but also after 2 weeks of termination. Then we do the same after 6 weeks of therapy and after a year of therapy to actually assess their healing. StrongMinds, we have we've evolved over time. When we started the community mental health intervention, we started with our staff leading the groups in the community. They were the one doing the mobilization, they were the one screening, and they were the one treating. But we saw that our reach, we couldn't reach a good number of people. So we transitioned to now peer-led therapy, where we had expert clients, those clients that had been in groups and they had actually benefited from the group and opted to also scale these to their fellow community members or clients that were going through the same. So we adopted the volunteer or the peer-led model being offered by clients with lived experience. We train them, of course, and we take them through the therapy process. Then we scale to the NGO partnership, where we work with other organizations to integrate into their programs. We believe that our model makes their model better. So by integrating that, we see an impact on their already existing programs. Those are the HIV program, also the income generating programs and other programs that the other partners do offer. So we also scale to adolescent work, where now we have adolescents out of school in the communities that are also trained to offer the interpersonal psychotherapy for the fellow adolescents in the communities. We also scale to the government partners, where we are now also training the healthcare workers within the facilities to be able to offer therapy, but also support the work that we do in terms of integrating mental health into the government structures. And on that, we've seen our treatment outcome We translated from on this slide where we see the cost per patient. Initially, when our staff were doing the therapy in the communities, we had a high cost per patient, was around $317. But as we kept transitioning and evolving and coming up with new innovation, that's why now we see that our cost per patient has now reduced to $13 per patient, and this is why we call it now the most cost-effective model to addressing mental health issues. Now in the community, how the model is delivered. I already mentioned that the community health workers within their communities, they have been in the communities and they trust them. We train them through a 5 days training to offer and deliver the mental health care within their own communities using the interpersonal psychotherapy for groups. The clients are brought in groups and be able to receive the treatment. But also we train, we do clinical supervision where we have brought on board 200 healthcare workers. These healthcare workers are attached to facilities, government healthcare facilities. So we use them to supervise the teams that are working in community for us to be able to safeguard the quality of therapy that is being offered, but also to safeguard the clients. So we are making sure that the work we do is of quality so that we do not compromise the care that is being delivered out there. And within that, we also have what we call the continued medical education for the team that is doing the support supervision. So we have ongoing session with them to equip them with skills in mental health, but also on how to offer therapy. We also came to learn that not every health care worker within facility is equipped with the skills on how to offer the interpersonal psychotherapy for groups within the community. So we take them through those continuous sessions so that they also develop their skills. And at some point, they also have groups that they facilitate. We also, within the system, we administer what we call the scorecard, the facility scorecard. This tool, we've been able to administer it to 207 healthcare facilities within the areas where we work. And this is used to track for mental health integration within the routine health service care package, because we believe now in the integrated service delivery where we assess the facility ability to screen, to identify, but also to treat those that could be having issues with mental health, but also being able to know the cases that are being referred to the facilities regarding the mental health issues. So as StrongMinds, we've had impact on the clients that we've treated. Over 2 million people have been treated of depression since 2014. And of these, we see that 74% of the clients on average are depression-free after treatment. And they have really recovered from depression and anxiety that we actually identified them with at the beginning of therapy. But also I've realized the spillover effect that comes after the clients have been treated, and we've seen that from results, we have 115 clients who report not missing their economic activity over the past weeks after they have attended therapy. We also realize that 85% of clients that report feeding their children 3 meals in the past 24 hours, at least after they have gone through the therapy, and also have a 29% of the clients that report that their children did not miss school over the past 2 weeks. We all believe that when someone is depressed, it disempowers someone and the functionality of the individual goes down. But we see this spillover effect, and we also see that that for every woman that we treat, you can move, that for every woman that we treat, we have 4 members of the family that feel they have benefited from the therapy. Actually, they are not the one that have attended, but because of the caregiver who has attended, it has a ripple effect on them, and they feel better because one family member or a woman has been treated. So thank you so much. This is what we do at StrongMinds. I'll call upon Christine Atgoza, my colleague, who has a lived experience from the community therapy groups that we've treated or reached out to. Yeah. Thank you. Thank you. Christine.
Yes, thank you so much, Rebecca. You don't know if, good afternoon, team. I'm happy to be here to present my life experience. Thank you so much, everyone. I'm glad to be here. Thank you. At 14 years, I lost my dad. When I lost my dad, the dad was taking care of us. We were 6 children when the mom left. It was 2007, remaining 1 day to start my PLE when my dad died. I was worked
Sorry, Christine, I think you're breaking up a bit. Can you hear me, Christine?
I wonder what could be happening.
I know. Christine, you'll let us know if you can hear us. Maybe. Okay. I'm sure Christine will try and rejoin. Oh, Christine, can you hear us?
Probably she can remove the video.
Yeah.
Might be affecting the network. Christine?
Yeah, I see her camera has turned off. But maybe while she rejoins, I can hand it over to Milani. Maybe we can start with any questions that we have from the chat. But yeah, over to you, Milani.
Sure. I don't have any questions in the chat, but please feel free. I see a question from Gafsa. Let me just see. Gafsa. No, it's not a question. Is there any questions?
I think
She
that
asked, Gafsa asked, is there mental health wellness? Is there any programs mentioned? How long this training? I'm sure she's referring to the people at the healthcare facilities. How long is that training? And be careful not to exclude psychiatrists and psychologists. And she also asked if they are reaching out to rural areas and villages. And then also, how are they getting funding? It's actually a lot of questions.
Thanks, Milani. Rebecca, I think, that question was for you on from StrongMinds.
Sorry, Michelle.
Mm-hmm.
I beg. What's the criteria?
Oh, yes, to the question again. I think it was, as Milani, what was it again, Milani? Please,
They
yeah.
wanted to know how did they get funding for these programs, and also how long does this training take to train the healthcare workers?
All right. We have how we get funding. We have donors that give us the funding, and we offer a modest stipend to the volunteers that do the work. We do not pay them per se. The training for the healthcare workers to be able to offer support supervision, but also understanding the concepts, the interpersonal psychotherapy concepts and the model. We do a 5 days training for them. The same train, yeah, it's a 5 days training for both the healthcare workers and the community health workers.
Okay. I was very impressed with the scorecard, the clinic scorecard. I wish every clinic in South Africa would have a scorecard like that. Is there any... Sorry? I see Christina has joined us.
Yes.
Please continue, Christine.
Okay, thank you so much. I'm very sorry my network got disrupted.
Right.
I was saying I was 14 years. I lost my dad, and the dad was taking care of us. We were 6 children when my mom left us with the dad. I started working as a maid, earning some little money so that I can provide basic needs to my little younger sisters and brothers. I was forced into marriage when I was still young so that I can take care of my young ones. I started working there. The husband, I got 3. I produced 3 children, but the husband started mistreating me, misbehaving, abusing me, beating me, denying me to get the basic needs at home so that we can use. I was hopeless. I was very sad. I lost interest. I couldn't even eat. I couldn't even sleep, all the time crying. The life was very difficult during the death of my dad. I tried to take myself using poison, but I remember I had 3 kids. Guess what? The StrongMinds team came to the ground at our village. Then they came and started sensitizing, mobilizing people, talking about the mental health and depression. Then they went through the sensitization. I realized that they were talking about some of the symptoms and triggers, and I realized I had those symptoms in my life. The life was not good. The life was very hard to me. I accepted to join through that experience of symptoms which I had. I joined the StrongMinds therapy sessions for 12 weeks. When I was during the therapy of 12 weeks, I shared my painful stories with the members, and also the members shared their stories to our group so that we supported each other. StrongMinds team and the members in the group supported me, encouraged me, advised me. They gave me support and encouragement. My life started changing slowly during the therapy period of 12 weeks. I gained hope. I opened my business. Remember, I couldn't even go to work. I was happy. My happiness returned back. I was able to interact with other people because before I was lonely. I can socialize myself. I started engaging hope. I had hope. I started believing on me. I practiced self-care on my side and myself. The life started changing, and the behavior, positively. And during that period, I was, after the 12 weeks therapy, I joined since I had that experience of the symptoms of the mental health and depression, I joined the StrongMinds training at one sub-county in Uganda, so that I can join and I get that training so that I can help other people who are going through the hard situation, a difficult situation like I was. I had a 3 days training on mental health and depression. I was very happy because I gained the experience and skills how I can implement the mental health and depression in other people. After the training of 3 days, I came back. I started as a volunteer, a mobilizer, mobilizing the male and women at the community on mental health care and depression. I started facilitating the groups, supporting other women and men so that they can come out from the depression and anxiety of those sorts. I continued working with StrongMinds, supporting that time. During that experience, I supported Inoka during the COVID time when there is no way no one can move from one to another place, that period of lockdown during COVID-19. I supported many men and women through teletherapy counseling, calling them and guiding them, talking about depression and mental health illness during that hard, difficult time of COVID-19 on lockdown. I also implemented on mental health care and depression on randomized control trial, the RCT. I supported that so that we can implement the IPT model on mental health care. Right now, I'm very happy because I'm very happy because I enjoyed that I was invited and I invited to do the interviews as a mental health coach in StrongMinds team. Then they appointed me as a mental health coach in Masaka. I worked in Masaka, Mayuge district. Right now I'm in Masaka supporting other people. I continue supporting the group. Right now I can support 8. Right now I have 8 volunteers whom I'm mentoring, coaching, giving them the knowledge or the skills on the mental health care and depression, how they are going to implement the model of IPT to the ground so that they can support those women and men suffering from depression on mental health care. I can support even, I have 16 health workers whom I ment and coach. The cluster leaders, community cluster leaders, I have 12 of them whom I can support and mentoring, coaching, so that they can implement at the ground, at the community level, the model of IPT on depression. I also support the ESS cluster leaders, what we call the education support supervisors and the stakeholders as well, so that they are supposed to implement the information on the service at the ground on the mental health care and depression at the ground. Right now I'm very happy because I'm a different person. Now I'm happy I get the skills. I can mentor other people, more than 80 volunteers whom I work with. I also, StrongMinds, after the treatment, I'm able to take care of my children. I can pay the school fees. I can take care of myself. I also went back to study. The next year, I'm completing my diploma. Thank you so much, team. I'm happy with StrongMinds. Thank you so much. Thank you so much, everyone.
Thanks so much.
Thank you so much, Christine. Thank you. I wonder are there any other questions? We are running out of time, but maybe we can just allow one or two. I don't see any other questions. Any other hands? Nothing.
We also have responses to the questions that were posed on how we work with the psychiatrists. There's a response in chat there, yeah, from Charlotte. Yeah.
Thanks, Rebecca. Oh, yes, I see Charlotte has put a response through. Bharti, yes, we see your hand. Please go ahead.
Thank you. Yeah, I'm so glad I managed to catch up and be part of the webinar. I just want to say to the speakers, just hearing what happens at community level in such a detailed way, really it inspires us to know that, it's just how many people can be touched by a program. And the benefits to the community. I think it's valuable lessons, and I think, yeah, we can also look at partnerships, how we could reach out to Rebecca, and look at opportunities for training, best practice models. I like the way you capture your statistics and show the impact, because it tells the story of your reach. And the same with Cape Mental Health, just by talking about the lived experience of people, it benefits, someone who doesn't understand what these programs are all about. It gives you a good idea of the impact that can be reached in communities. So thank you for that.
Thank you. Yeah.
Michelle, do you want to wrap up for us, please?
Of course. Thanks so much, Melanie. Thank you, everyone, for your questions, and to all attendees. But extra special thank you to our speakers. Thank you, Christine, for sharing your story so honestly. And it sounds that StrongMinds has really helped you to find a new lease on life. And that's so beautiful to hear. Thank you, Rebecca and Carol, for sharing. I think it's been such an insightful session, especially when we hear these excellent examples and lessons from two community-based mental health organizations in very different spaces, different countries, but really understanding that community mental health should be at the heart of the mental health landscape, not just in South Africa, but globally as well. So thank you again. Over to you, Melanie.
Thank you so much, everyone. And I think the message is clear today. There's help available. But there's still a lot of work to be done, breaking down stigma, breaking down attitudinal barriers. But thank you for the many dedicated people, the wonderful programs that are actually working around the clock to help us cope with everyday life and with all our mental health issues. And thank you so much for everybody that joined this afternoon. And from my side, a special thank you as well to all our wonderful speakers and Michelle for leading us in this session today. And I'm wishing you a wonderful afternoon further. Thank you so much, everyone.
Thank you. Bye-bye.
Bye-bye, everyone.
Thank you.